Right, I'm just trying to record this presentation. Sorry about the delay. We're just trying to figure out the technology here. And this is my first time using this platform. So I actually have no idea if anybody is hearing me clearly. Can somebody just indicate if I'm coming through okay? Okay, awesome. Thanks, Owen. All right, so let's get started since we're a little bit delayed. All right. All right, well, thanks for the introduction, Soham. It's a pleasure to be here with you guys. I remember as a med student doing Health Equity Week, and it was always a fun event, getting speakers, and I guess now, after a few years out of AMSA, that makes me an OAT, if you guys are still using that term. So the presentation that I was putting together is called Towards Equity and Empowerment, focusing on global health disparities and opportunities for change. And Soham might have mentioned that I had spent a number of years during and after med school working with a community-based health program in rural India. And so I'm definitely going to rely upon that experience to help guide this presentation, but hopefully introduce some other theories and perspectives that I've encountered from meetings with experts and readings and literature and so forth. But I did end up creating a fairly broad presentation to kind of help you guys see the complexity of health equity as well as its close cousin, empowerment, because there's just an endless amount of perspectives that you can bring into this conversation, and it's just fascinating to me. The more I learn about it, the more I realize how little I know about health disparities and equity. So here we go. Oops, there we are. All right, just some objectives for this presentation. We'll just skim over that. And what I'd like to do is start off by examining the meaning of equality, which seems pretty straightforward. And of course, most of us believe equality is good, right? Well, it often is, but it's certainly not the same thing as equity. And in simple terms, it means doing the same thing for everyone and applying one universal standard across the board, sort of a one-size-fits-all approach to whatever program or intervention that you're implementing. And there's an excellent analogy that I picked up from a professor at UNC, Dr. Vijaya Hogan, who's an expert in this topic, to really help visualize this concept a little better. So what you're seeing here are three people standing on three identical boxes. And what they're doing is trying to peer over a fence to catch a better view of a baseball game, which you'll see in a second. So in this analogy, the boxes represent the inputs, actions, and interventions that someone, say, running a theoretical program would try to incorporate to achieve whatever goal they're after. Now, the same rules and regulations are applied equally to each and everyone. In this case, the boxes that they're standing on are the same dimensions. In the next slide, you can clearly see that the inputs, while they're the same, they're not enabling each individual to attain the same goal. So equality does not always imply equity, especially if different people or populations are starting out from very different positions in society. As we all know, some individuals and groups are certainly more vulnerable and have higher risk for various illnesses for reasons that are not always of their own making. So therefore, equity aims to promote fairness and justice. But equality alone is not going to be enough, since it assumes that everyone starts out from the same place and needs the same things, essentially. It only concerns itself with the inputs. And in the real world, different populations will require different inputs in order to achieve similar goals. So true equity-oriented programs, they have to figure out what is that so-called what else element, as you can see depicted here. And this is so vital to narrow the gap between those who are privileged and those who are marginalized. And to illustrate this point, I'm going to show you some examples and case studies that depict readily measurable health outcomes of inequalities or disparities in different societies, especially pertaining to child health, which has been measured probably better than a lot of other indicators out there. All right, here we go. So this graph, you can tell that immediately that it's demonstrating stark differences that exist between different regions around the world in terms of under 5 mortality over, I would say, a 45-year time span. And as you can see, even though the gaps are narrowing, the ratios are still relatively well preserved between the regions. And what's also interesting to notice is that certain areas around the world have outperformed the global mean, especially looking at the aggregate of what are known as the MENA countries, the Middle East and North Africa countries, and to a lesser extent, East Asia and the Pacific region, which is in orange. So the MENA region, in particular, offers an interesting case study for us in this discussion because it places health equity squarely within a socio-political context. And there have been studies, actually, to try to understand what could have accounted for this greater than average improvement in the health status of children relative to other parts of the world. And of course, there's much diversity within this region. So it would be too simplistic to generalize across the board. But there are a lot of commonalities here that we can rely upon to make some conclusions. So, and the majority of this region's population, which is greater than 700 million people, they reside in middle-income countries, namely Iraq and Iran. About 9% live within the oil-rich nations. Those would be Bahrain, Oman, Qatar, UAE, and Saudi Arabia. And the rest are found living in low-income countries such as Sudan, Yemen, and Djibouti. And remember that it includes the North African countries. And these low-income countries have an average per capita GDP that's even smaller than the average sub-Saharan African country. But the cultural similarities and the geopolitical factors that tie them together really help us draw some conclusions here. And these can help us see more clearly the underlying social and political processes which produced what we see in the data. And the UNDP reports were put out not too long ago that offer specific details on this very issue. So I'll attempt to summarize some of those key points for you. And I don't have a slide for this, but we'll just go through it step by step. And policies addressing human development have been a considerable focus for most countries in this region. And I'm referring mainly to improvements in access to education, especially for girls, and access to public health services in many of these countries. Of course, we all know there are major problems that these societies are dealing with, such as high youth unemployment rates, social unrest, and autocratic rule. But nevertheless, these countries have proven themselves to be high achievers in reducing child mortality and deaths from communicable diseases. Another point is that from the perspective of the West, we think, or many people living in the US and European countries think that women are very much oppressed and marginalized in this part of the world. But there are significant differences at the state and household levels. In fact, girls in many of these countries have been given considerable opportunities to attend publicly funded educational institutions, even through college level. And some researchers and authors believe that this dynamic, along with more progressive family planning policies that were rolled out in some of these countries as early as the 80s, they had an important influence on the dramatic reduction in fertility rates, as you can see in this slide, pretty much across the board. It's also important to note the fact that significant wealth from oil exports in some of these countries has given those governments an ability to invest much more heavily in the social sector, including universal health care and education for all of their citizens. Now, I don't have a graph for this, but relatively lower levels of income inequality were also found to be significantly associated with improvements in the Human Development Index, which some of you may have heard of. And that's a fairly important point. And since the majority of these Middle East and North Africa countries fall into the middle income category, the data indicate that they are relatively more equal than other developing countries with similar characteristics in terms of income distribution, education, and measures of women's empowerment. The reports from the UN also mentioned that it's plausible that under the right circumstances, the reduction of patriarchy at the level of the family, as in Iran since the Islamic Revolution, can expand women's access to education and work outside the home. So it's quite a dynamic picture here. And what's really interesting just to remember is that these countries did invest quite heavily in the social sector and health as well. So moving on, let's take a look at a few other graphs which depict the percent of children underweight in various regions of the world. In this case, from 1984 to 96, and in the next graph, from 1990 to 2011. So what's striking in both of these figures, I would say, is the disproportionate number of malnourished children in South Asia compared to the rest of the world, even in relation to sub-Saharan Africa, despite common notions and preconceptions about children living in sub-Saharan Africa. And we are not just talking about raw numbers here, since that would obviously skew the data, since the large combined populations of India, Bangladesh, and Pakistan are immense. India alone has 50% more people than 47 countries of sub-Saharan Africa put together. But this data is rather measuring malnutrition prevalence, or percent of children under 5 or underweight in each of these regions. And you can see how the trends continue through the 90s and up to 2011, as reported by, I believe, UNICEF and the UN. Just going back for a minute, I want to point out the statement that they write here, the Asian Enigma, and that caught my eye a while back while living and working in India. Apparently, researchers who study this phenomenon try to understand the complex situation which produces this disparity that sets South Asia apart. And the Asian Enigma is a concept that has gained much acceptance. First of all, you need to consider what happens at birth. So across the world, low birth weight is the best single predictor of malnutrition. And we know that a weight below 2,500 grams, or roughly 5.5 pounds, is found to be very closely associated with poor growth throughout childhood. And when you look at data from the World Health Organization and UNICEF, it's clear that in India, 1/3 of all babies born have low birth weight. In Bangladesh, the proportion is 1/2. Now, in sub-Saharan African countries, the proportion on average is about 1/6. So the other major factor identified has been the association of childhood diseases, including diarrheal diseases, which can influence a child's growth. And children who are affected by chronic illness are more prone to have poorer growth, given their negative effects on nutrient absorption and their ability to disrupt the intestinal lining. You also have to take into account fever and appetite suppression from these illnesses, which are consuming calories and restricting absorption. And a major determinant of diarrheal disease is access to safe drinking water and sanitation services, especially at the community level, as many of us realize. When you compare South Asia to the sub-Saharan Africa region, you'll find a higher proportion of families in South Asia have access to water, although it's often unsafe drinking water. But relatively fewer of them have access to sanitation services. And especially, this has become a popular debate among public health practitioners and policymakers, is the practice of open defecation, which has typically been very pervasive throughout South Asia, mostly in the rural areas. Of course, overcrowding in slums, which are quite infamous throughout South Asia, especially India, can also contribute to this situation, since you have people living in such close proximity with often very inadequate infrastructure around them. Now, along with the availability of food, clean water, and sanitation in the prevention of disease, the issue of exclusive breastfeeding, especially in the first few months of life, greatly influences the risk of developing malnutrition. But here's where it gets more interesting. Studies have shown that almost 50% of all babies in South Asia are exclusively breastfed for the first 4 months of life, as opposed to only about 1/4 or 25% in sub-Saharan Africa. That's according to the World Health Organization. So then in theory, the infants of South Asia should be better off. So why aren't they? Well, the particular ways in which the babies are breastfed can render breastfeeding less than adequate for an infant's needs. Though it seems unlikely that women in sub-Saharan Africa are prone to more correctly breastfeeding their babies compared to women in South Asia, there are cultural differences that may account for some of this. And for instance, in India, the initiation of breastfeeding is frequently delayed for 1 or 2 days. And we're mostly talking about poor rural areas. And this may be attributed to some common beliefs or mythology that colostrum is not healthy for babies, and so women often discard colostrum, unfortunately. It's also a practice in some regions to supplement breast milk with water and juices, which may not be as nutritious and certainly not as safe as breast milk. So another point to bring up is that at a certain time towards the middle of the first year of life, all children, regardless of where they are, need complementary foods to supplement breast milk in order to meet their nutritional requirements. And the introduction of these complementary foods represents a critical stage in the child's nutritional progress. So in sub-Saharan Africa, the proportion of breastfed children ages 6 to 9 months who receive complementary foods is almost 2/3, whereas if you look at Bangladesh, India, and Pakistan, it's less than 1/3. And given the propensity of South Asian children to become malnourished starting at 4 months of age, it leads us to believe that there needs to be even earlier introduction of complementary foods in those high-risk areas. So the last point I want to make in this case study has to do with the mother's nutritional status in the period leading up to the pregnancy itself, and in the postpartum period. And it's known to be a significant determinant of the child's weight trajectory. In South Asia, many women are in fact underweight, and the rate of anemia is quite high throughout their adolescence and certainly continuing into the pregnancy. And this typically goes hand in hand given the underweight and the anemia, given the practice of early marriage. Because these women get cut off from their families early on in life, and they're often subject to the rule of the mother-in-law, who in many cases is not the most sympathetic person for these women. And another topic that has received relatively little attention is the fact that, especially in poor and rural areas of South Asia, the girl child and women have a significantly lower status at the household and community levels relative to their male peers. And while working in this region myself, I've often heard very tragic stories of families where you see their substantial preference in terms of food quality and quantity being given to the boys regardless of the level of need, rather than equally dividing the resources among siblings. And much of this is actually carried on by older women of the household who seem to perpetuate these kinds of practices. And while sometimes it's intentional, this unequal treatment of boys and girls by parents and entire communities in some cases represents a more deep-rooted cultural belief about the value of the girl child. And of course, it's not just exclusive to India. This often is found in many Asian countries and in parts of Africa. But it also underpins why the sex ratio in India, especially in North Indian states, has become so significantly distorted. And it's certainly attributed to practices such as sex-selective abortions and even infanticide, which have been documented. And even later into adolescent and adult life, the lack of freedom for women in many of the poor communities of South Asia limits opportunities for socializing even among themselves. And so this condition restricts transmission of new knowledge about health matters and childcare. It damages their self-esteem and induces a kind of crushed dependency on the husbands and brothers. In Africa, women certainly have many disadvantages in society and have rights restricted. But oftentimes, the greatest obligation for women in those societies is to look after the children and to be caretakers. This is in contrast to the situation in South Asia, where often the needs of the husband and the mother-in-law factor much more heavily into a woman's daily responsibilities. So this situation begs us to consider interventions not just to improve access to higher quality nutrition and education, but also to take a much more gender equity oriented approach in promoting health and prevention of diseases, especially at the local level. Women have to be factored much more heavily into this equation, and their participation is vital to ensuring a reversal of the trend of inequity in childhood malnutrition and mortality rates at all levels of society. This case study is interesting because it lays out a sort of cultural basis for some of these disparities and gives you another way of thinking through what shapes these numbers, because you have to consider the inside world that exists within these countries and communities, as well as the outside factors that modify health and disparity distributions. And so let's take a look at this next graph. We can also see how tremendous disparities, in this case still underweight children, can occur within individual nations, even to a larger extent than they do among countries of different regions. And for instance, take the case of Burkina Faso, where the wealthiest 60% have a proportionate number of underweight children as the poorest 40% in Kenya. So this example illustrates the complexity that goes into study and intervention design when it comes to addressing these health disparities. So generalizations can certainly be very misleading and lead us to make the wrong conclusions, especially if you're looking at data from a region or even national data. You really have to break it down by various measures. The next two graphs are from the US and are simply meant to depict another product of health inequity which exists among a country's ethnic groups, especially when it comes to minorities. And the trends here merely remind us that while combined national or population health statistics may be quite favorable, the situation for certain minority groups may resemble that of a lower income country when it comes to outcomes, as you can see depicted here as infant mortality among African Americans and Native Americans. So this is precisely why we must look beyond achieving equality and press more towards attaining a fair and just system of health and politics that works for all its people. So in my own state of North Carolina, these disparities are quite palpable from my perspective as a healthcare provider working in an underserved area in Western North Carolina, which certainly puts a face on these statistics. And the way a country responds to this situation and allocates funding is to a certain extent telling of the political will to address health disparities. As you can see in this graph, since the late 1990s, there has been a significant increase in the allocation of funding for health disparities research. And I believe that came about with Clinton's Health Disparities Initiative. And today, most of the national centers for clinical and public health institutes have expanded components to address disparities and equity in health and looking at the social determinants of health, which is a great thing. I'll just skip over that. And for a moment, let's switch gears and consider a related issue that ties into all of this, and that's the issue of poverty. And we have to ask ourselves, how can we hope to affect these vast disparities that exist within and across our borders when poverty in many regions seems so intractable? Well, in fact, there is a growing understanding that poverty in itself may not be the single most important influencer of the distribution of health within a population, which may sound surprising. But measures of income inequality and distributive justice appear to factor very heavily in health disparities, such as those we looked at earlier. And I'll bring in a few examples of this. But let's consider for a moment the reasoning which has been proposed by politicians, economists, and some social scientists to try and explain the existence of poverty. Because whether you're working at the community or international level, before you can effectively start to implement that what else component, as you recall, it's going to be important to try to understand how people and entire groups can end up in such disparate circumstances. And this is a very broad topic in itself, and I'll just point out a few key things. There's certainly a historic argument that can be made, and anybody who's read Jared Diamond's book called Guns, Germs, and Steel will be familiar with that. Basically showing how accidents of history, geography, climate, access to resources affected the distribution of power early on in the developing world in terms of Europe, Eurasia, Africa, the Americas, and why it is that military technology developed faster in certain parts than others, leading them to conquer, to be sort of play the role of conquerors and colonizers. But to explain the modern distribution of poverty and power imbalance, the issue is today often addressed through two opposing but somewhat overlapping viewpoints. And to some extent, these issues try to get at why the distribution of poverty that was laid out so many decades, centuries ago, why they still exist in their present form. And the first of the poverty is mainly the result of inequality of opportunity, meaning that through various incidental and circumstantial reasons, individuals and even entire cultural groups get cut off from resources and opportunities that would help them achieve the freedom to move within society economically, physically. And proponents of this ideology, they often look at economic indicators, GDP growth, employment opportunities. They push for strengthening the private sector, rule of law. They focus on governance, reducing corruption. On the other hand, the second camp in here, in this debate, they study poverty and determinants through a different lens. These people use the term structural violence often to describe institutionalized racism, gender inequality, classism, etc., which they note determine who has access to money, power, and in general the distribution of health outcomes as a consequence. And people like Paul Farmer have used this theory in their work to bring about positive changes in some communities they work in. Now, take note that these structural forces are closely intertwined with the social determinants of health, and those are more downstream factors shaping the vast distribution of preventable deaths around the world. But as I mentioned earlier, the measures of social equity or inequity and income distribution factor very heavily in the magnitude of poverty's impact on health outcomes. Take, for example, the case of Japanese men who smoke compared to American men who smoke. Here you see Japanese men smoke at twice the rate of American men, yet they have a much lower associated mortality. So clearly the underlying mechanisms are more complex than simply the disease process itself. Here's another quick example of where equity-oriented initiatives were associated with impressive gains in the health status and quality of life. These would be the four Asian tigers, namely South Korea, Taiwan, Hong Kong, and Singapore. They promoted universal education, land reforms, housing, water and sanitation became important public policies, and universal access to basic health services was instituted. And a similar combination of social programs was also implemented in the Indian state of Kerala and in the nation of Sri Lanka, along with education for girls. And these areas around the world have greatly outperformed some of the neighboring countries by many measures of population health and social progress. Then, knowing this, you may wonder why it's taking us so long to achieve meaningful progress, and why are we constantly pushing back targets such as the Millennium Development Goals instead of following prescriptive actions that have already been tried and tested. But you need to think about who controls global health from a systems and policy perspective and who drives the changes to a large extent. And many of you will recognize Margaret Chen, who is the Director General of the WHO. And this organization is certainly considered a leading body for health policymakers and health system administrators who draw expertise and guidance on a vast array of topics. How about these two guys, who you undoubtedly recognize? Large private and public agencies and global health foundations often play an important role in spearheading research trends and driving large-scale interventions or demonstration projects, which may otherwise receive inadequate support. But they're not immune to their own internal politics and the influence they receive from national governments. Remember, they also have donors and people that they need to please. In fact, the majority of funding agencies much prefer, historically, single-issue, evidence-based, and time-bound interventions, which are really more easily packaged instead of the far more reaching, comprehensive programs that are systems-focused and would require multi-sectoral coordination and have local management. Those are much more complicated interventions, even though it's been shown that those comprehensive approaches are the most effective. And it would be short-sighted of me if I didn't mention the multinational corporations that have become significant players in affecting and shaping the daily lives and decision-making process for billions of people, even in remote corners of the world, where such corporations as Coca-Cola, you'll find people in dusty villages in the middle of India having access to that. So the process of globalization, with its improved telecommunications and transportation networks, have affected the way people live their lives. And certainly this has had some positive and some negative consequences, which is a topic in and of itself. But there's no one single answer here. But when you really get into it, what becomes clear is that the most powerful organizations who have the greatest influence on national health systems are the financial organizations, namely the World Bank and its counterpart, the International Monetary Fund, or IMF. They're essentially extensions of powerful nations who have historically pushed pro-Western development policies on low and middle-income nations, or so-called emerging economies. And these included in the form of structural adjustment programs, which many have argued in the development sector have weakened equity-oriented programs and favored the so-called free market reforms, including fee-for-service health systems like we have in the U.S. And you can see these measures as austerity measures, which in essence reduce social safety nets that were so vital for many vulnerable and marginalized groups. In some cases, you can even find written proof that government officials were explicit in the self-interest of their administrations. And you can even find quotes that were declassified from the U.S. State Department from 1948, as you can read here. But something happened in 1978, which was sort of a turning point that was presented to the world. And it took place in Almaty or Alma-Ata, Kazakhstan, of the former Soviet Union. And the World Health Organization and UNICEF convened a large international assembly to draft a declaration on the concept of primary health care. Not to be confused with primary care as we use that system in the US. The organizers of this conference included the Director General, Hassan Mahler of the WHO, and he invited 3 to 4 representatives from 134 governments and 67 international organizations to participate. And the members called for a paradigm shift from merely addressing income poverty to looking at human poverty within the framework of a comprehensive system of primary health care. And we're going to look at the meaning of that. So this meant addressing barriers to opportunities and choices most basic to human development, and to allow people to lead long, healthy, and creative lives and enjoy a more decent standard of living. And this didn't come out of thin air. These ideas were built upon decades of experience from small-scale, community-based organizations throughout the world, which piloted and experimented with these concepts on small scales. And these were the specific criteria of primary health care which the Declaration puts forward. As you can see, they focused a lot on education, about health, and also they promoted secular education as well. Promotion of food and nutrition, safe water and sanitation, maternal and child health, family planning, immunizations, factored heavily in the preventive work that governments should be involved in, prevention and control of locally endemic diseases, appropriate treatment of common diseases and injuries, and appropriate is a term that can mean different things in different places. And of course, provision of essential drugs, and they created a list of the most essential drugs. So the Declaration went even further to emphasize the importance of working alongside the poor and seeing them as active agents or partners who can take ownership of health and development activities, not just passive recipients of aid. So this implied minimizing the role of professionals and relying much more heavily on local expertise and valuing and honoring that expertise as well. People's participation in a Health for All movement was key in all this, and empowering women and minorities as agents of change, as well as ending all forms of discrimination, were additional progressive ideas that were put forward by the conference organizers. And to depict these ideas more concretely, you can think of a Venn diagram to see how this declaration viewed health and development. It was basically equating health and development as being two sides of the same coin. You can't achieve one without the other. It also promoted the idea of intersectoral coordination, which I alluded to earlier, and comprehensive primary health care, which involved working with systems-level interventions, not just sort of low-hanging fruit, such as micronutrient supplementation and single-issue research elements like malaria and HIV/AIDS. Instead of seeing those things, rather seeing those things within a system or a cultural context that you need to acknowledge. Of course, the aftermath, the years later following the conference, didn't produce the intended result. And here, Dr. Mahler commented his disappointment on sort of the failed or inadequate effort that was made by countries to roll out and implement these elements of primary health care. Another one of the organizers of this conference was Carl Taylor, who was one of the founders, what many would say, of the field of international health in the U.S. And I had the honor of working with him for about a year before he died at Johns Hopkins. And he has a famous quote where he said, "Health professionals who have a tendency to feel that health is dependent on them must recognize that health by the people is critical to development." So the concept of empowerment, which became such a central theme was unfortunately underutilized and misinterpreted by many well-intentioned people. Since this is so often misunderstood, I wanted to provide a clear definition of this. And social scientists studying empowerment define it as a social action process by which individuals and communities and organizations gain mastery over their lives in the context of changing their social and political environment to improve equity and quality of life. Empowerment and from an action-oriented perspective, program planners should realize that empowerment-based health and development programs need to seek to enable individuals and communities to obtain appropriate knowledge and skills and take responsibility for critical assessment, decision-making capacity, and the means of engaging in meaningful collective action on issues of local importance. And this was the cover of the World Health Report in 2008, which was very promising because it told many of us who are firm supporters of primary health care that there is still some initiative within these large organizations, such as the World Health Organization, trying to push for a comeback of these principles. So primary health care is a concept that hasn't fully been realized, but also not quite dead. And I'm going to conclude with a series of slides depicting an organization and NGO that I'm intimately familiar with through firsthand experience. And it's called the Comprehensive Rural Health Project in Jamkhed, India, in the state of Maharashtra. Since 1970, the Comprehensive Rural Health Project, or CRHP, they've demonstrated that the principles of primary health care as laid out in the Alma-Ata Declaration can certainly be implemented, and even on the shoestring budget, which they had in the beginning. And their mantra has always been the principles of equity, empowerment, and integration. So this is just a map depicting where Jamkhed is located. As you can see, it's central India, in the state of Maharashtra, just east of the Western Ghats, which run down the west side of India. It's a very drought-prone area, very rural, cut off from major cities and road networks. That's one of the reasons they decided to start the organization in that region. And these were the founders, Drs. Raj and Maybella Rowley. Both of them have passed away, Raj just a few years ago. But their children and a lot of early staff are still part of the organization pushing forward. And the Rowleys realized very early on that you needed to have the support of local women, community health workers, as they trained, who intimately understood the communities, who were accepted by the communities, and who could speak the same language. As they tried to bring in outsiders, even outsiders from the perspective of the villagers, who would see anybody from outside of their immediate area as a foreigner. And nurses and auxiliary nurse midwives, they were used in the beginning, but with very little impact in terms of health education and helping people overcome centuries-old practices, such as wasting the colostrum or avoiding certain foods which may be high in nutrients, but people thought would be bad in pregnancy. So just overcoming those mental barriers that are so ingrained and which only an insider can really hope to address. So these women were given training and skills to go out in the community and undertake a lot of these kinds of change processes. But they weren't just abandoned, they were often incorporated. They were always incorporated into the health system that this project organized, including a hospital, a health center, a training center, and a mobile health team that navigated between all the components. And as you can see in this slide, they would get together once a week for refresher training and meetings, and they would exchange ideas and solutions. This was key to the strength of these village health workers, because they were able to learn from each other much more than they did from the health professionals. Here you can see a village health worker checking blood pressure on a pregnant woman in her village, and she's being supervised by an older village health worker. So they often work in tandem, passing the information and knowledge from one generation to another. And same thing is going on here. And really, this is the heart of equity. It's just meeting people where they are, going door to door. The poor oftentimes don't have the ability to travel to faraway health centers for checkups. So this system of local primary health care was essential in leading to some significant health improvements, as I'll show in a few slides in this region. So here you are, you can see sort of a sisterhood mentality among the village health workers. And you have to go there to really experience what these women went through early in their lives. Some of them have been raped, beaten, just mentally tortured by husbands and their in-laws. Some were kicked out and made outcasts. A lot of them are from low caste, and they would be called Dalits in India. Used to be called the Untouchables. Here you see growth monitoring, village health workers going around their community, weighing babies and recording them on charts. That enables communities to respond very quickly to any child who's falling behind. And in this case, you see a member in white of the farmers clubs that they also organize. Farmers clubs focus a lot on water conservation, watershed management, and they also help in the work of the village health workers, providing them support. And here one of the health workers is using teaching aid, which is mostly picture-based since there's such a high literacy rate. And this one in particular is demonstrating how to put together rehydration solution for a child who has diarrhea. And these are the kinds of tools that are needed, not just the generic CDC or WHO health education handout. They need something that is accessible to their own frame of reference. And you can see in the background, there's a board in each community, in each village, that highlights the statistics, the most relevant health statistics for each village. Number of births, deaths, children with malaria, TB patients, leprosy patients, anything that the community members thought was important to track. And this is amazing because you can go to any of these villages and instantly see what the health situation is. It's all transparent, and people have a greater ability to target those problems when they see them flat out in front of them. And this is just one of the most amazing village health workers that I've worked with. Her name is Lalambai. She has been with the project for over 40 years, and in that time she's delivered probably close to 1,000 babies. They do get intensive training on safe delivery practices because many of these women do deliver at home. And she's just a pillar of support for her community. She's almost become the mayor in many ways. And she's also a master trainer, so they bring her in whenever they're doing a new batch of community health workers. This was, in the front you see Mabel Aroli, who's, as you recall, one of the founders of this organization. She was very passionate about helping these women become empowered. And she would describe empowerment not as something that they're doing to the women. It's just enabling an environment where women can gain those skills and confidence to go about and talk to people in their community about issues that are important. So they also focused on water utilization. They worked with the government and other nonprofits to install bore wells which go very deep into the ground to provide safe drinking water. And they were very strategic about installing these in the low caste areas of the villages so that these people would not get cut off by the upper caste. And that is a situation which still exists in some parts of India, despite popular thinking. And another important intervention here is organizing nutrition programs. So you can see children coming together from the community, and the farmers clubs and the village health workers, and also the women's groups that were later organized. They would assist in cooking and feeding these children. And the farmers clubs did an amazing job of collecting grains and crops and other foods to provide to the neediest families. So that kind of collective action didn't require a lot of outside aid. It was actually very minimal. They were able to organize their own resources and strengthen from within. That's Raj Aroli helping women figure out how to use their new watches, which they were given. They were bought for something like $2 a piece back then in the village markets. These watches were used to help them with health monitoring. They would be able to take somebody's pulse, record a child's respiratory rate. It enabled them to diagnose and treat pneumonia among children in the community and other things. And really, in some cases, an empowering tool as well, because it's sort of a status symbol. The training center was also developed right next to the hospital, and they often have camps to diagnose and treat cataract disorders, where large numbers of patients come in, and there's a robust team of health professionals helping to triage people and provide appropriate care. And it's almost, you could think of it like a conveyor belt. There are so many people, and they might do 50 cataract surgeries in one weekend. The same thing for tubal ligation and other common diseases or health needs that can be identified in this area. The hospital does provide low-cost secondary health care, including general surgery and obstetrics. This is just a health worker screening adolescent girls for anemia. You could see a new addition in Jamkhed during a C-section. Children are often treated for various disorders in the hospital at a very low cost, affordable cost. And the organization, CRHP, has become very open to receiving outsiders who want to learn about this model and perhaps incorporate it into their own context. And we have many students who come in and take courses of varying length, from 1 month, 2 months. Custom courses can be designed for universities, and we have a lot of medical students and public health students who come in from time to time throughout the year from dozens of countries around the world. And they get to see the communities, they get to interact with the health workers and the community groups. As you can see, students come to the villages for discussions with community members, and as well as classroom demonstrations. And this is a chart demonstrating the improvement in the health status of this area. And time is running short, so I'm going to really wind up here. You can see the greatest change occurred from the years 1971 to 1976, where you had a very significant decline in Jamkhed in the infant mortality rate, the utilization of maternal services, including antenatal care, safe deliveries, immunizations of children, malnutrition. Everything started to dramatically improve. And 5 years is not a lot of time to implement such changes, because they require really intensive change in the mindset of people to really change behaviors and thinking. But because they were so integrated into the local cultural context, they made this possible. Even in 2007, you can see the last year that I have the data, they outperformed India on pretty much all of these measures when you look at the national statistics. So I'll just end with this quote from ancient Chinese author, which the people of Jamkhed often use to depict what their philosophy is, and it says, "Go to the people, live with them, learn from them, love them, start with what they know, build with what they have. But of the best leaders, when the job is done, the task accomplished, then all people will say, we have done it ourselves." All right, on that note, I can take questions if we have anybody, if we figure out a way to do this. All right. And you can unmute yourself or just type any questions you might have.